Thank you very much for a very warm welcome. It's a great honour to be here. As I've just been introduced, I am Head of Operations for Insight Healthcare for the South, so I have a very big remit to cover. And this is a really exciting, inspirational event to attend, and I do feel honoured to be part of it, so thank you for the invitation. I'm one of the Insight Healthcare, one of the 9 IAP providers that cover cover the whole of Kent and Medway. And we are a primary care service. So what does IAP mean to everybody in the audience? We deliver NICE approved treatment for people with common mental health disorders, so low anxiety and or depression. IAP services are very rigorously examined and monitored. We have to address routine outcome, and that's routine outcome monitoring, and that's done by KPIs, DSM orders, minimum data set that is submitted to NHS England, and PEQ questionnaires. PEQ questionnaires is a patient's experience of addressing our services, which is really important to us, and it helps us develop our services and pathways. We deliver evidence-based psychological therapies, and we have a very skilled workforce. By that we mean that all our therapists are qualified and accredited to either BACP or BABP. The counsellors, many of them are UKCP, so a very experienced workforce. And we have to work really hard with that workforce to maintain their accreditation. In line with that, there's skilled supervision outcomes that have to be there. And with the step 2, the psychological wellbeing practitioners, every fortnight they will have clinical skills and clinical supervision, and every week they have case management. And then likewise our step 3 practitioners, the high intensity practitioners, will have an hour and a half supervision, clinical supervision every month, plus case management. We operate the step care model. So from referral to assessment, that is step 1. And then we've got step 2, if it's deemed appropriate for that client following their assessment, they'll be accessing guided self-help, whether telephone, face-to-face or Skype. And that's delivered by qualified psychological wellbeing practitioners. If it's deemed that high-intensity therapy is more appropriate for them, then the clients will be referred to a range of modalities, which could be CBT, EMDR for single trauma, IPT for interpersonal therapy relationships, and counselling services. There's also couples counselling for depression. So a part of our routine work, we do have to follow national targets. And as part of that, we have to get a minimum of 50% of our clients to recovery. So they get to clinical recovery. They've made a really good improvement from when they've accessed services. And we monitor that by using GAD and PHQ scores. And we've also monitored by our national waiting times. From referral to assessment, there's an expectation that somebody will be in treatment between 6 to 7 weeks. So what does that mean for Kent and Medway, and who is providing these services? You've got 9 providers that cover this area, Insight being one of them. So you've got Dover Counselling, Faversham Counselling Services, IESO provide online support, ourselves Insight Healthcare, Medway Talking Therapies, North Kent Mind, Psychon, Think Action and University Medical Centre. So you've got a really broad range of providers here, but you've also got a very diverse population and a huge geographical area to cover, which does bring its challenges. So I've previously mentioned about outcomes for the IAP services, but just want to share with you some of the achievements that have been recently made within the last 12 months for the resident population of Kent and Medway. Over 48,000 referrals have been received by the IAP services in Kent and Medway. That is a huge volume of people that's accessed the services and come through the doors. Of those, 31,000 entered treatment, 51% moved to recovery, and 72% showed clinical significant improvement. And even more pleasing to say, 75% were treated within 6 weeks of referral. So all the KPIs that were expected to do have been met. but they've also been met with excellent clinical outcomes, which is really pleasing to see and pleasing to report on. And I can share with you, as I previously said, I do cover a very big geographical area from North Nottinghamshire, Basset Law down to Kent, and this isn't reflective in every area. So I think it's a real good commendation for the excellent services that are being delivered to the resident population of Kent and Medway. As previously mentioned by many other speakers this morning, the 5-year forward view also come along with the mental health services, and there is a big remit in there for the IAP services. And it is bringing huge challenges, but no more challenging than what's being faced by any other services that are addressing the new demands. The biggest demand is that we've got to expand our access rates from 17% to 25%, and this has got to be done by 2021. That's a huge impact to get an extra 8% of referrals through the doors of all the IAP services. We've also got a new initiative from DWP. I'm saying it's new. Really, IAP Services was originally born to help people get back into work, and it seemed to have morphed along its way and got slightly lost, and it's now back on the radar. So there's been a phase 1 and a phase 2. Medway have been part of phase 1 for employment advisors, which means now actually in situ, in their main offices, they've got their own employment advisors and a senior employment advisor that sits part of their senior management board. So they are really integrated into the service. The difference with this approach is anybody wanting to access the employment advisors by IAP are actually identified within the IAP service. And that's either on referral or partway through treatment. And it could be many conditions. They might be on long-term sick due to their mental health. It could be short-term sick. They may need some rehabilitation back into the workforce. But the employment advisor are on hand to do that. And I have to say that within weeks of being in placement, they soon got up to maximum capacity and are doing very, very well. Another big area for us is to reduce inequalities in access and outcomes. And really that stems back to some work that was done in 2014 by Layard and Clark, who identified that people with a long-term condition were underrepresented in IAP services. So I just want to take a little pause there, and I hope that's given you a very quick synopsis of what IAP services do. And I think you'll all appreciate there's not a lot of time for us to go through this, but I just want to show you some patient stories. Insight's had a video made that goes through 1 in 4 people will suffer from a mental health condition, and we've just got 4 examples on here. These are live examples that are taken from patient experience questionnaires. They are portrayed by actors, and it is an Insight video, but I'd like to just say that it's the characters in here will be truly reflected in every IAP service across in Kent.
I was feeling so overwhelmed at university, moving home and new city, just really struggling. Insight offered me online therapy where I could access support that fitted around my lectures and in the comfort of my own home. It was brilliant, and now I feel like I'm in a really good place.
3rd pregnancy. Having experienced 2 miscarriages, I was so worried, would I experience another loss? Insight offered me CBT, and within weeks things were clearer. I had a helpful way of managing my worries, and now I have a healthy baby daughter.
Worked for 15 years, then made redundant. Never completed a CV before. I was worried about finding work. I felt ashamed and worthless. Insight Healthcare offered me an employment advisor alongside therapy, which gave me the skills and confidence I needed to move forward.
My wife has dementia. I was only focused on looking after her and forgot about me. All alone and no one to talk to. I attended a workshop which helped me to understand why I was feeling so low. I was with like-minded people and not alone.
So we have got the directive for focusing on people with long-term conditions, and there is a lot of rationale as to why that. As I say, they're underrepresented within IAP services, but also 2/3 of people with a common mental health problem also have a long-term physical health problem, greatly increasing the cost of their care by an average of 45% more than those without the mental health problem. So by integrating the IAP services, we can provide better support for this group of people and achieve better outcomes. By this, we are talking about true integration and not just using that as a terminology. The key is to encourage this client group to be able to better self-manage their condition. In 2017, NHS England defined the integrated IAP to ensure that we were all addressing the right needs. And I think for me, there's key things that came out of this definition. Number one, expand access into services. Number two is for people with long-term conditions and or medically unexplained symptoms. Number three is integrated physical health. Four, being part of a multidisciplinary team so that therapist isn't sitting on her own and the physical health team aren't sitting their own. They're truly integrated around the same table and they've got that patient at the centre of the care. They're putting a good, clear, wraparound care plan for that patient, having the patient at the centre of the focus. Importantly, ensuring that all the treatments that we do are evidence-based. And if we can get this right, then we know that the clients are going to have a better outcome. The one thing I need to express here, there is a point in there about long-term top-up training for IAP therapists. This does not mean by any way that they become an expertise in their field. It simply means that they've got the confidence to explore further about the presenting physical health condition. They dare ask a question about insulin dependent, whereas prior to this training, they wouldn't have had the confidence to do that. So that's merely what it's there for. So the challenges that it brings to us, many challenges, but as I say, not like any other services. At the moment, we've got core IAPs, it's self-referral. And as it says, self-referral, GP can recommend people referring, family members can recommend anybody from the physical health team and mental health teams. So we've got a core IAP service that we report on directly to NHS England. We've now got an integrated IAP that has got a same system-built reporting management that we have to do, and then we've got one for the employment advisors. So we've all had to do really big systems changes. But I think the key thing for this is about the integration, and this is what NHS England are really championing on. And I think it goes a little bit to Dr. Ahmed's presentation earlier in secondary care about the integration. And I think the important thing for us is to not reinvent the wheel. We know that the physical health pathways are out there and they are very successful. It's just where do we fit in? Where is it most appropriate for IAP to tap into those pathways? And where is the re-referral route? Because somebody could get to recovery, they could have a relapse, and where do we make it appropriate for them to come back into services? And again, it's making sure that the patient is at the centre of care. There's cross-learning to be had from secondary care services and primary care services, and that is about that joint working again to ensure that we can improve the self-management for the patient's condition. IAP clinicians will learn from physical health teams, and likewise it's going to be a dual learning. So the physical health teams might then be able to identify that there might be a bit of anxiety or a bit of a low mood that they perhaps didn't see in the patient the last time, but they can just have a word with the therapy next door and just say, what should we do about this client? And I think it's fair to say that we know that expertise in the fields, and both sides of the fields, if working together, we will get better outcomes for the patient. The difference with the integrated IAPT and referrals is it's not a self-referral. It does come directly from the physical health teams. So, for example, if somebody is in a workshop for Katie or Derek for diabetes, it'll be the nurse in charge, the diabetes nurse in charge, that might suggest they refer to IAP. They might have some mood disorder or something that's just identified that's not normally, or they've not previously seen it. Importantly with this, what we are also trying to do is ensuring that the healthcare teams do consider the carer. And it isn't just the patient that's going through this pathway, the carer's going through the pathway as well. They're seeing the changes in the physical health conditions and the next step of their treatment. And we do try to ensure that the physical healthcare team are encouraging the carers, if needed, to access core IAP, to self-refer into our services, so we can give them coping mechanisms to help them deal with their loved one's condition a lot easier. The outcomes that we're expecting from this, there's many. All the patients that come through integrated IAP will fill in a CSRI, so it's a client service recovery impact sheet. or impact assessment. It's done at entrance of service, it's then repeated 3 months down the line, and then it's followed up at 6 months. It does glean a lot of information from the number of GP visits, the number of A&E admissions, transfer to hospital, the number of unelected stays, medication. There's a whole host of evaluation methods that are used in there. We don't have the outcomes yet, but as soon as we do get them, we are willing to obviously share them. But that is one of the main methods that we will be looking at to see what impact the integrated pathway has had. And hopefully a big reduction in prescribing, because it is about getting the person at front of door before they hit the prescribing programme. There's lessons learned, and I'm conscious of time, so I'm not going to go through all of them, but the key ones about building the relationships and ensuring those relationships start off with appropriate way from the primary care psychological teams and the physical health teams, that we're there to support each other and to try and make this pathway work together. Ensuring that we don't do crossover commissioning and that the plans that we do are not already being commissioned. And I think most importantly that I'm just going to close on is patient focus groups. When we've got the patient that's walked the patient pathway and they're pleased with that, we know we've got it right. Just want to leave you on a metaphor, and again, this has been on a little bit that said, some of you got the Chinese finger traps on your tables, and I just want you to consider that we've got physical health and mental health, and we've got a patient in the middle. Mental health are busy, physical health are busy, and it tightens and it traps the patient. They're not in control of being able to make the decisions to self-manage their care. But by working together and considering that patient at the front of it, that patient is released and in control of their self-management. Thank you very much.
Grab a seat, Rose. I'm not sure. Yeah, we've got a couple of questions, okay? Okay, we have a couple of questions. How do people access CBT for hoarding disorder? Microphone for Rose?
Oh, you might be able to hear me, actually.
Well, hang on a sec, it's just here.
I'm not a clinician, so I can't claim to know the absolute answers, but my experience of people that access our services will have an assessment, and if it's ordered, it would normally come under OCD, so there is a disorder specific for that, and they would receive treatment.
Okay, thank you. Do we have another one? If I want to train to be a low or high intensity practitioner, where do I access the training?
The best form of access would be to keep a lookout on NHS jobs, because we are always recruiting for trainees, and another bout of recruitment has just happened in this area, and they'll start university in March, and they should be, if HEE release the funding, there should be another cohort in September. So I just keep registering and keep looking on all the NHS websites, and indeed keep an eye out on all the IAP websites as well, because we do advertise positions there.
Thank you, this is going well. Is there an opportunity to work with liaison psychiatry to support those with long-term physical conditions and mental health issues?
I think that's... I'm Deborah Fraser, I work in the East Kent commissioning team, and I think there's definitely an opportunity for us to talk to the liaison team and look at how we link together.
Great stuff. Nice to see you, Deborah. I wasn't told you were going to be here, so welcome to the stage. Any more? Oh, on the floor, okay. Who have we got on the floor? The mic's on its way. At the back there. That looks like Alison. Do you want to introduce yourself, Alison? Give us your question quick as you can.
Oh, ex-KMPT worker, but now here from charities and local organisations. Just wondering about what efforts you're making to improve the access for older people to IAP services, because they've been very poorly represented nationally. Whether or not they've got long-term conditions.
Hello, it's something that I think there's a few of our providers in the room here will know that we regularly talk about and look at the programmes that have been successful. There is definitely an opportunity to increase access for older people, and we worked with our public health colleagues to identify those areas where there's greater need. And we have got some pockets of expertise in our providers of working with older people. But it's definitely a part of the area of focus of increasing equity of access.
Right, thank you very much. That's all we have time for on that one. Thank you both very much, Deborah and Rose.